Meeting is starting. So the recording has started. I am now letting everybody on in from the waiting room. So good morning, everybody. This is Dominic Zerlo with the New Mexico Department of Health, and just welcoming you all to the Medical Psilocybin Advisory Board meeting. The chair is Ian Dunn and the vice chair is Dan Jennings. And at this point in time, I will turn the meeting on over to Dan to start at things. But just as a reminder, we do record this meeting. And so please make sure to keep language appropriate for recording as we do put this out publicly. And the other thing, just to remind everyone, that is one of the reasons why we also, other than board members and some of the team at DOH, we also keep cameras off for two reasons. One, to ensure that there's nothing in the background that would prohibit us from posting the video of the meeting onto the website. And two, just in case people are in areas that do not have great bandwidth, this way they can actually stay in the meeting and they don't drop nearly as often out of the meeting. And so we do have that. And so with that, I will turn the meeting on over to Dan. So thank you, everybody, and welcome. Dan, meeting is yours.
Appreciate it. Thank you very much, Dominic. And I know that we've got an agenda here. Hi, everybody. I'm Dan Jennings. I'm the chair of the Research and Continuous Improvement Subcommittee and also the co-chair here of the board. And so I appreciate everybody being here today, and especially all the other board members that are with us in the Department of Health and all of you from the public that have decided to join in for our regular board meeting. So I would love if we could go ahead and call order, make sure that we do have everybody here. I know that I see everybody from my board here, so I would love it while we're doing this is to have everybody from the Psilocybin Advisory Board introduce themselves and say hi to everybody. And so we'll start with Brenda.
Good morning, everyone. Thank you for coming to this meeting today. I am Brenda Burgard. I chair the Training and Education, and hope this will go really well today, and needing all your participation in forging ahead and making everything great. Okay.
Thank you. Appreciate it. And is Alana on? Alana Dances.
Hi, this is Keenan Ryan. I am the acting chief medical officer for Medicaid, and I am covering for Dr. Dances today.
Perfect. Thank you for being here. And Desba.
Yeah, today, good morning, everyone. I'm Desba, and I chair the Equity, Access, and Cultural Considerations Committee. If you have not done so today yet, take a deep breath and settle in. This is going to be a great meeting.
Thank you, Desba. Appreciate that. And Dr. Larry Lehman.
Yeah, hi, Larry Lehman, chair of the End of Life Committee, and great to be here. We had Brenda's committee and our committee had a great meeting together last week. I look forward to sharing some of that.
Thank you. Appreciate that. And then, of course, Chris Piskuski.
Morning, everybody. Chris Piskuski here. I'm a veteran and no longer, I'm a chair of propagation committee, but we've largely wrapped up our work. So I'm just here to support everybody else. Thanks.
Yes, thank you very much. And you're right, the rule setting had gone through for the last one, and I know we'll get to that through updates from the program in a little bit. And now on to program staff. And so Dr. Zerlo, if you wanted to introduce everybody and let from your team and let them share.
Good morning, everyone. Thank you. And just to keep it a little shorter, I'll just go through and introduce the Department of Health team members. So to start, we have Jorge Gonzalez, who is our psilocybin program manager. We have Cyrus Routman, who is our environmental scientist. Leslie Peterson, our compliance officer. Johnny Mouche, who is, his official title is management analyst, but he is really the glue that keeps us all together administratively, and will be helping us out today. We have Dr. Robert Truckner, our medical director. We have Selena Montoya, who is our finance director, and who is here to help and assist down the road as we start looking at things such as how we handle payments with regard to equity fund. Not that we're talking about that today, but so she has a good idea as well of what's happening. We have Adrian Estrada, who is one of our health educators, and I think that is all of our current team members that are here today. I'm just double checking to make sure I didn't miss anyone. But yes, that is everyone that we have online from the program today. So thank you.
Thank you, Don. Appreciate that. And stick around for just a second. We'll get an update from the program in a bit. So just to go over the agenda, and also, by the way, please let me know when Ian Dunn gets on, and so that he can then take over the chair position too. So just give me a heads up. Tell me to stop talking. Our agenda today, we will hear from the program and the updates that are have happened and coming up in the future. We've got a couple of potential recommendations, one on clinical roles, and there also was one that I saw come from another committee that we'll share a little bit with Patient Qualification Safety Committee, which did have some committee consolidated recommendations. And again, Ian's here, I'll let him present, but otherwise I'll kind of share and we'll be able to have discussion on that. And then we'll have updates from the other committees and hear from the report outs from them, any other business that might take place, and then we'll set our next meeting date and location. We'll move into public comment at the end, and that'll allow anybody to, up their 3 minutes to kind of share whatever you'd like. So to move on to the next part of the agenda, updates from the program. So Dominic, anything you'd like to share?
Thank you, Dan. Really, right now, things are moving along on schedule, where things have been happening pretty smoothly for the most part. And that really is due to all of the participation from the board members, from the community, and we really appreciate that. And I just want to let everybody know that I am very grateful that we have as many people participating and providing information and feedback, because that's really what's going to make this program in the long run. So thank you to everybody on that. And really, the other update that we have is just that we did have, back on the 24th of April, we did have the rule hearing for the cultivation and testing rules. And so those are continuing to move forward. We have not yet gotten the report back from the hearing officer. So until we do, and until we have that, we don't have any additional progress on that front. But we do anticipate receiving that within the next couple of weeks. And once we do have that, then we will take it to the next step. And that essentially is, if the hearing officer has said, yes, that these rules do fit in with regard to the statute and are reasonable, then we can move forward with propagating them, or promulgating them rather. As you can tell, I've been looking at cultivation quite a bit lately, but with sending those on out and them going into effect. Once they do go into effect, we are working on what the applications will look like and how those will be handled with regard to cultivators and testing facilities or laboratories. Those are outlined within the rule, but we have to get the practical side set up. And so the practical side is we will be doing this all through digital means, so online. And so once we have the rules have been promulgated, then we will be setting that on up, including dates. Our anticipation is that we will be able to start receiving applications with regard to cultivators and testing labs by about the middle of July. Now, again, that does depend on if the hearing officer states whether the rules are appropriate or not. If the hearing officer, by the way, says that no, we need to go back and do additional major revisions on the rules, then we will do so, and then we will go through the process with the committees and the board, and then have another rule hearing. So just so everybody is clear, those are the two different potential pathways. As we have more information, we'll bring it to either the committees and to this board, depending on when the meetings are. So, but that's essentially the big update that I have from our side. Jorge, is there anything in particular you would like to announce as well?
No, not at this moment.
Okay. All right. So thank you, everybody. Are there questions from the board for the program? Nope. Okay. Back to you then, Dan. And it does look like Ian has not been able to join. We have messaged to him. But what I would say is if you do want to hold off on the review of the clinical, maybe it might be good to do the updates from the committees. Might just be my recommendation.
Sure, we can move that to updates from the committees ahead of that, and then we will. I'm very happy to kind of share what has been coming out from. I believe it was from the Dosage Administration Clinical Practice Committee, and then the Patient Qualification and Safety Committee. Those updates from Ian's team too. So I don't mind taking that if he doesn't come in by that time. So perfect.
Okay.
No problem. Then let's go ahead and I'll let any of the board members that chair any of the subcommittees just go ahead and we'll just kind of do it as a round robin. So whoever would like to go first, please go ahead and unmute, and whoever speaks first will go first.
Okay, fine. Hi, this is from the Equity, Access, and Cultural Considerations Committee. We met, I want to say, a couple weeks ago. We have a new meeting on the 19th. And I think it was the 13th that we met. No, the 6th. Sorry, the 6th. Days and everything is blurring in together with me. But we met, it was in person. So hopefully we can get another in person as we move along. And that was a hybrid. So you could also Zoom in and meet in person. And it was at a building here in Santa Fe. So what we had from that committee, we were able to establish, and this has not yet reached the board just yet. We still have some more meetings to kind of solidify this, but we established a baseline for a scale to start from, to hand over to the DOH to look at, to kind of give some scaling numbers. And what I mean by that, this is where I was saying like the math nerds and everybody else. What we're looking at is just the baseline for the poverty line, the baseline for like how we would be able to help anyone who is interested in participating with the equity fund. So this is for the equity fund. And at this point, we were looking at 200% poverty line. So I can't remember, I think that was like roughly 60 some $1,000 a year annually. And the reason why you're using the percentages is so that can fluctuate based on income, et cetera, and as that moves, because it's based on the federal poverty line as a starting point. And then we were trying to cap it around 600% of that. So after 600%, a person would be responsible for paying for a full cost of treatment. Now there's a lot of other variables involved. And so if anyone like actually is able to kind of wrap their head around what that means, great. But basically it's just, within the 200% and the 600% based on the incomes, trying to find within there the different scale for how much of the equity fund a participant might be able to get. So there's a lot of math involved. I don't want to like give too much away, but just if you have the mental capacity to wrap your head around these things, please come to the Equity, Access, and Cultural Considerations meetings. We have a presentation set for next week to talk about these things and what that could look like. We have a lot of different variables, but right now we're just basing it on income for now, and then we'll start adding in all the other potential variables, which could be, an access to the equity fund, which could be for caregivers, for childcare, interpreters, and that sort of thing. And those variables will then, move that needle a little bit as to how a person might be able to access the equity fund. Another thing to consider was just the amount of people that this equity fund could be able to provide money for, whether it's like, just a handful of people, and being able to really solidly help them, versus maybe stretching that money a little bit more. So again, if anybody is interested in numbers and equal access to funds that we have available to us, it's $630,000 for the equity fund that we were trying to figure out the best way and the most amount of people, but also to do it the right way, to do it as equitably as possible. So that's our big push right now. And then we'll start dealing with when we have the access. We're also waiting on a tribal liaison. We're also waiting on a native sovereignty leaders, public council leaders, to be able to kind of get a gathering of everyone together. So we can actually talk about other parts of what equity, access, and cultural considerations really looks like. But right now, it's the biggest goal is to look how to cut up that equity fund for people. So again, everyone come to help figure that out on the meeting on Tuesday at 3.
Thank you, Desba. Is there anybody from the board that wanted to, any questions or anything for Desba's team? Thank you. Appreciate it. Who would like to go next? Which committee?
Well, I'm going to drag Larry in with this, and so Larry and I can talk about what our meeting was all about last time with end of life committee. Well, is it a committee or is it? Yeah, the end of life committee. And what does training look like? What is everybody's position and role? Larry, you can jump in at any time. I'm just going to ramble and you can jump in. But it was really good. I really enjoyed it because I think what happens to all of us is that we get into our silos and, we're working on things. And this was really very eye-opening for me to see how Larry's group is coming around to all of these different aspects that could be in the education and training committee, because I think this is a part that doesn't get a whole lot of attention as far as therapists go. Like myself, I don't have any training in end of life or the quality of the life that people are experiencing during their time when it's ending. So this was a very important part of this education and training, and I think that should be added into probably one of the competency curriculum that's there, because there's just so much to touch on, but this is, I think, one of the most important ones to learn about.
Thanks, Brenda. I can drop in a little bit of information about one of the areas that we focused on. Can anyone put my slides up there? I know I sent you guys the slides. One area that's come up a lot with end of life is just, how do we have the roles for non-licensed providers? How do we have models if, assuming that there's going to be at-home care? And so we've, have a couple of different thoughts that we've shared that in our group, and we shared with Brenda's committee. And I was going to try to show just a few slides of that.
We'll have that up for you in just a minute, Larry.
Okay. I can fill up the space till then. So what we're looked at is really the idea of that there may be two potential ways for non-licensed providers to be able to be involved in this, and one of them is a role that it could be what we would call a facilitator role, but it's not a facilitator role that's licensed as it is in Colorado and Oregon. Okay, good. We have the slides here. And if you want to flip those into slideshow mode, that'd be great, but otherwise it's just fine. So one recommendation from the end of life committee is that everybody that's involved in end of life psychedelic care have at least 28 hours of training specific to end of life care, and that could potentially occur during people's core training. But the feedback we've gotten is that that much doesn't usually happen, and we think that as Brenda mentioned, the competencies for end of life can be somewhat unique. They can involve other areas, but palliative care, spiritual care. So that was one recommendation. What came through that is some clarification, and Dom was very helpful there at the meeting of the role of the lead practitioner, and then ways to proposing roles for assistant to the lead practitioner. And we see that there's two different roles that could be assistants. Next slide. So just to remind us all, the lead practitioner, as defined by the Bill of the Regs, really is limited to certain groups here, and so the issue is how can other people get involved there. I would skip to the next slide. Actually, it's a little more up to date. So one idea is, that trained lead practitioners from non-clinical or community-based pathways, and the idea that there could be a non-licensed facilitator that can be participating under the license of the licensed provider. And we have several ways that this seem to be relevant to end-of-life care. It could be somebody who's a death doula, it could be a chaplain, other spiritual role, or a legacy provider, someone who's been doing this work for perhaps decades, but will not be able to become licensed. They also could potentially have a full 150-hour training, similar to what people happen in Oregon, Colorado. But it would be very appropriate to have that non-licensed facilitator have recognition for prior trainings and experience. Next slide. We also looked at even a more limited role of assistance. And part of it, we realized that there needs to be two people, especially if there's going to be at-home care, and one of them would be the licensed provider. But we're trying to develop a role that can be somebody that's more of an assistant there. We came up the role, and I want to give credit for this name to Hanifa Washington, the space attendant role, supporting psychedelic assisted care at the end of life. And this could be someone that works there, supporting the licensed, practitioner, the client, and family members. The actual training for this could be relatively limited. We thought it could be like a 40-hour training, a 40, 50-hour, where half of that would be on end of life care. And for the other half, we thought modeling something after Zendo, which is dealing with emergency psychedelic care, and people could get that training. So that could potentially be 40 to 50 hours. Again, it's a non-licensed role, but one that we could, be very supportive, and it would certainly make it easier to have two people in the home without having to have the expense of two licensed people. Next slide. Little qualifications, a little bit like for this space attendant training could be completion of a psychedelic sitter peer support, such as Zendo, supervised practicum or direct experience, which preferred, and other training there, and then whatever state required certification that we're suggesting for end of life training. This person, we think, when we're dealing with the areas like a hospice care, that we're optimistic that they actually could be a volunteer, that there are a lot of people do want to do volunteer in hospice and end of life work. And so it could be that role. There also can be like a stipend role. We can see a lot of people that may be interested in this role. People could be doing that, that are potentially retired, or people could also be doing this as sort of a way of getting exposure to the space there, maybe before that's a little bit of a pun, exposure to the space, right? Before they decide to get more of an advanced training. So that would be another role for this person. Next slide. We also were recognizing, that there's also, besides the people that are licensed or assisting client-directed family members, that spiritual providers or chaplains who may not have training to be a lead practitioner, death doulas who may decide not to be trained as a facilitator or lead practitioner, and other people, and that all of these folks are potential members of the care team. So we talked about a lot of other stuff with Brenda's committee, but I
Yeah.
thought this would be interesting as people will start looking at, the other indications, like who might be appropriate for other members of the care team for the other indications. So thanks for listening.
Thank you, Larry. Thank you for taking the lead role on this and, describing what was said in the meetings. And yeah, the Zendo project is another one that um, really attends to people who are in distress, especially for, um, uh, when people are experiencing adverse effects. And Dan, I wanted to tell you also that in your meeting, when I was attending your meeting, I mean, you really got into the nuts and bolts of exactly what is done in attending, a patient. So I'm really just in awe of all of the work that everyone is doing here, because as far as education and training goes, this is going to be integrated into the core competency roles that everybody needs to do. So it's going to really build a real robust curriculum, I think, for a lot of people. And I think around 150 hours, we want to try to align that with Colorado and Oregon. And I know, but that would be from start to finish for someone that wants to learn about how to do this kind of work. That would, I see, as I'm looking at all of this information, would be really appropriate and aligned. That's my opinion. But we'll see what the DOH decides at the end here. But as far as reciprocity and all of that goes, I think having like a core competency for the reciprocity, and then having like an a la carte type of thing for people that do qualify for all the core competencies, but just want to add on or have more of a better foundation for here in New Mexico. And I think I was mentioning it last time, especially for for um, practicing the initial practicum of everything that needs to be done, because a lot of people have been kind of sitting with their certifications from Oregon, Colorado, and California. They're all sitting on it and just waiting to see what we're going to be doing in DOH. And another thing that I see happening is a lot of people are wondering, what their roles are as far as unlicensed co-facilitators, guides, space holders, or whatever we call them at the end here. They're really wondering, and I really try to tell people, hey, come to these meetings. You really know what's happening here as far as that's concerned, because I think what's happening is people are having groups and talking about all of this, but they're not really seeing what we're doing here. So anybody that's fresh and new to this meeting, I really encourage them to look over our past recordings or past meetings and get caught up on what we're trying to do here, because I think a lot of people feel like they're getting left out, but really we want co-facilitators. We want that there to support the practitioners that are licensed. And I think that's all I have to say right now.
No, appreciate that, both of you. Thank you very much, Brenda and Dr. Lehman, for sharing. Before you walk away from this, please share if you have upcoming meetings for either or combined from your teams. If you have those dates already planned or anything like that.
Oh, yeah, I have one on the 22nd. And if anyone wants from the board wants to join in that meeting and participate in the core competencies. It seems like I'm kind of going over the same information all the time, but it gets a little meatier as we go along, because we have to kind of add more things into this. And usually it's just a curriculum that we are looking at, and I know there are many teachers out there for psychedelic therapy. What that's going to look like for New Mexico, we're just trying to make it our own and make it as equitable and fair as possible. And I think if anybody from the board wants to join in on that meeting, that's fine with me. I'm just going to be going over the same information.
Perfect, thank you. And Dr. Lehman, you're muted as well, so if you wanted to.
Sure, thank you. We've heard end of life committee is on June 5th is our next time from 1 to 3. And yeah, I'd love to have people join. I think one of our focuses may be starting to talk about issues of prioritizing. I mean, we've talked about how we have a very expansive view of end of life, that it might include someone who, you know, has many years to live. But as we start thinking about limited funds in the equity fund, I think that we want to open up the discussion to see how we would look at, is there like an appropriate way to prioritize people for that. And so ultimately, Desmond, that may be a great thing for our groups to kind of link up on. Thank you.
Thank you, sir. Appreciate that. And Don, I saw your hand go up.
Thank you, Dan. I was just going to let everybody know that I had put the meeting notes in the chat, and apparently I may have just been a split second faster than Chris. So thank you to Chris also for also posting it. But that does list all of the currently scheduled meetings that we have at this time. So if anybody wants to check them on out and register for them, you can just click on those links and go to their individual pages for those meetings.
Perfect. Thank you. Then I'll give a share out from our Research and Continuous Improvement Committee. We had met last week and had a really good discussion. We've got some wonderful people that are been working on work groups, including Dr. James Brown and Gregory Evans, Danielle Leonard, Eileen Brewer, and have been doing, and I think Dr. Linda Fatemi had been doing some work as well. Doing a lot of work when it comes to, we try to focus a lot on patient fit and facilitator fit, focus on safety and reporting and data. And so for our last work group, what we decided to do is to really refine our responsibilities for the RACI committee to ensure that we work well with the other subcommittees and know kind of where our bright lines are, where we kind of stop, and where we can provide best reflection back, but also receive instruction from. So our three responsibilities we aligned on were the reporting framework. We needed to come up with a reporting framework first, because this is all centered around safety. We wanted to make sure that we have patient safety and patient data at our heart of this. The second responsibility is harm reduction and a quality improvement framework. And the third responsibility is the core and extended data set framework. And so by starting with our reporting ideas first, working back through the harm reduction and quality improvement, we'll finally land on the data set framework that we needed to have to support that. So we are broken into three kind of intersessional work groups. So between our monthly meetings, we have one that will focus on the care pathway and safety. We'll have one that focuses on the participant experience and fit. And then the last one will be more of the data and reporting architecture. So we've kind of aligned around the shared journey that a participant will go through from the first stage of preparation into session, into integration, and into an oversight or review framework. And so that kind of puts everything around asking, are you ready? How are you doing? What happened? And also, is anything wrong? And so the wonderful thing is that the team has identified a large battery of different protocols that exist, that are research-based, that are vetted, and are in the research sphere. So by utilizing those, they're aligning around how much of that is done by the participant, how much is done by the clinician or facilitator, and on. So therefore, they're working on that aspect. But kind of what we wanted to do around those 5 parts of the journey is to ask questions like, what should be happening at this stage? What risks or concerns arise at this stage? What should be documented what should be monitored and reviewed and what belongs in a core versus extended data set, so that way we can focus on the core data set, which will be important for ensuring program compliance and safety, monitoring, and then of course quality improvement is needed in the end. But there's also an extended data set that would be wonderful if there is the ability to, especially focusing on research. And so we wanted to align that so that way we don't have people that are looking at it thinking like this is way too much to have to put in for every single time. We wanted to have, here's the core. So again, that will be kind of the last thing that we'll work on. We do have meetings that are coming up. Our June 12th meeting, we always have this from 9 o'clock until 11. So on June 12th, that's when our reporting framework will come out. We'll kind of align around that to get a consensus. Then on July 10th will be our harm reduction and quality improvement consensus. So that will be presented, and then we'll work towards making sure we can solidify that. And August 7th will be the core / extended data set consensus. So hopefully we can get on this kind of regular monthly cadence. And so if you're interested in doing intersectional work between them, of course, informing and learning more about it, please join any of those meetings so that you can kind of hear. And of course, intersectional work, I always said, like from my teaching background, was like, okay, you get homework to do. And so it gives me a lot of homework to do in the back end, but it's great because the team has done an outstanding job of finding what tools and protocols that are out there that, like I said, are research-based and not kind of gut feeling. So it's been wonderful to try to focus around the idea of patient safety when we do this. So once patients have been qualified and they're going through, we really wanted to make sure that the system is centered around the patient and, again, the best fit and the care for the patient. So, and that is it for the RICES subcommittee. I do know that on our agenda, we do have some recommendations. And I believe that it was the Patient Qualification and Safety Committee, or the clinical roles, I believe.
Yes,
Yeah,
yes, Dan, I do have that,
Yes.
and I can bring that up. But Dominic, go ahead and finish.
I was just going to say the other recommendations are still in process. Because the board had determined earlier that they weren't going to be looking at petitions for new conditions until after the program had started up. I believe it was either like next February or March.
Right.
So I would say we can hold off on those, but if we move
I
forward
do-
with the clinical.
I do know the one that I received out of the Patient Qualification and Safety Committee was simply a tiered clinical support framework, meaning the qualifications of patients that fit one of those 4 already agreed upon standards, then their specific medical backgrounds were broken into 4 different tiers for standard support, enhanced clinical support. I do have it up as well. So
that does go more into the guideline side rather than regulations. So what I would recommend is looking as far as on the clinical roles, which just as a note, that was really, it's not, the clinical role portion isn't for adoption by the board because that's still being looked at by the training and education and end of life. It was more just here's sort of how it's starting and how things are moving forward. But we wanted to make sure, and I know Ian wanted to make sure that those got, at least the discussion started.
Perfect. That'll be great. And so we'll go ahead and have this presentation and then the discussion, but we won't, I don't know if we should take, there's no action to be taken on this, correct?
Correct.
Fantastic. Okay, great. Just so that I can be clear on this. So, and again, this is speaking on behalf of that subcommittee, so please understand that I don't know a lot of the answers from anything on this. And if there are any questions, I believe that would probably be best suited for that work group. But, and Brenda, I know that this will probably be very closely with your committee as well, so please feel free to jump in with anything on there. And it's on the screen and also in the notes and the chat as well for anybody to read if you cannot read from the screen there. So I'll go, yes, go Brenda.
Yeah, Dan, so I'm going to try to attend every one of your meetings, so I'm there to see how this is being formed. So all of the clinical roles here are aligned with what clinicians do. And also too, I think, if I can, I've been looking at a lot of your information and at Larry's information, and I want to kind of mesh the two together, but I don't want to start doing that just yet because we still have to look at some of these things as, these are, qualifications that all therapists meet in order to keep their license. So, but I love the way it's the details of this. So I may go ahead and if permission, take some of your information and also with Larry's information and try to formulate something here in the next meeting, just to show the public what clinicians are doing here as far as education and training goes, because it's this is the education and training part is really the boring part for the for the general public, because they're not practitioners. So this is geared more towards the learning and training part for co-facilitators and anyone that's licensed. So looking at this, I'm going to just kind of like put some things here and there in my next presentation, but it shouldn't, like I said before, it's going to be more of the same information that's going to be presented to the public.
Sure, absolutely. And this is coming from the Dosage Administration and Clinical Practice Subcommittee. So therefore, that'll be, Ian's subcommittee. So definitely, if there's anything on that y'all can work together on, please do. So again, I'm just kind of reporting out what was shared here, and this will hopefully help us to see where these different roles are. So one of the notes on here, you can read on the screen, of course, but the qualified individual could be fulfilling multiple roles where scope training and credentialing allow. So the first role that was presented was the clinician, which would be a psilocybin certified clinician, and this is defined in INMAC. It should be a licensed clinician acting within their scope of practice with the diagnostic authority. And so listing out different credentials there, including LP, CCMD, and DO. Responsibilities, this role will be identifying potential candidates based upon the qualifying condition. Right now, as Dr. Rose said, we have 4 certain qualifying conditions for entry, or certified qualifying conditions for entry into the program, share relevant diagnostic and clinical history with the patient consent in accordance with applicable privacy laws. Limitations mean that certification does not constitute clinical clearance, not responsible for determining medical appropriateness or dosing or safety planning or administration decisions. And so the recommendation that was made for education and training, so is establish the minimum education, continuing ed, and licensure requirements and define required competencies. And so that's that specific role, then that's what that role would take place in the medical psilocybin program. The next role is the practitioner. This would be a psychedelic therapist, defined in INMAC as well. The scope of this role is to conduct a comprehensive biopsychosocial assessment, review medical, psychiatric substance use history, identify contraindications and medical interactions, evaluate risk for psychological or physiological response, and create a safety plan, assess a support system, determine the medical appropriateness for psilocybin treatment. The responsibilities in this role are to evaluate clinical appropriateness for psilocybin use, including, but not limited to, medication interactions, medical and mental health history, and current functioning. If the patient is not appropriate, then refer them to a primary care provider or an appropriate treatment avenue. Using trauma-informed and culturally competent communication throughout the screening and treatment process. Assign a clinical support tier. Establish dosing, parameters, or considerations. Approve or defer participation based upon safety, and must be involved in psychological preparation. The limitations for this role does not provide facilitation unless specifically credentialed and does not conduct preparation or integration unless duly trained. So the recommendation to the Education and Training Committee is to establish minimum education and licensure requirements, define required competencies and assessments and contraindication review, interventions, medication interaction screening, risk stratification, and harm reduction. And the last role that has been defined is the facilitator role. Facilitator is an individual who has completed department-approved training and education, has been registered with the department, whose role is limited to providing non-clinical support and presence to a patient preparing for, experiencing the effects of, or integrating the effects of administration as allowed by the program. A facilitator does not perform and shall not be construed to perform clinical assessments, diagnosis, treatment, or any other act constituting the practice of medicine, nursing, or any other licensed health profession. A facilitator does not act under the supervision, direction, or authority of any licensed healthcare provider, and no provider shall be deemed to have supervisory responsibility over facilitators solely by virtue of their concurrent participation in any part of the program. Their responsibilities include to conduct administrative, I'll just let it scroll just a little bit up. All right. Here we go. Responsibilities including conducting the administrative preparation and integration sessions in coordination with a psychedelic therapist to obtain informed consent from the patient, support patient during administration session, monitor the psychological and physical safety during those sessions, escalate any medical or psychological concerns to the psychedelic therapist or appropriate emergency services, prepare materials for patient self-administration in accordance with approved protocols and psychedelic therapist direction, and document session activities. And the limitation of this role does not determine medical appropriateness independently, does not override contraindictions or safety restrictions. And the recommendation to the Education Training Committee is to establish minimum education, continuing ed and licensure requirements, and to define required competencies. So I know that in the chat, and we'll get to the chat in a little bit, there was a question, would the document be made available for future reference? And since this is probably going to be just a recommendation to a committee, I believe that there might be this might be included in the notes section on the website once this gets posted. Oh, there, thank you, Jorge, for recommending that. So, I'm going to let Brenda speak to these first, since this does have complete alignment in with her committee. So anything that strikes you, and then we'll open it up to everybody else also.
Thank you, Dan. Yeah, so this is pretty standard clinical practices. You know, that even though this is a little different because we are working with psilocybin and psilocin, this is part of the, you know, integrated to the program, and making sure that safety is paramount to everything that we're doing. I think it's done very well and can be included into the core practices of a clinician that's doing this work. So it's dead on. I mean, I don't really see anything else. However, I want to include, you know, any indigenous or tribal in that as well, and how that would be part of the core competencies as well, and have that as part of that. And that's about the only thing I see that needs to be included in this, and how that would look like. I do have something written up. I can't recall what it is, but I do have I think a little segment in another core competency that I'm working on right now, to have that as a part of this as well, so that safety and dosage and all of that is also included in all of this. So that's about the only thing I see that needs to be included. But I think this is being very careful about, you know, how we're treating people, how these assessments are done, making sure they are properly educated and prepared for this treatment. The other things are, again, I think collecting the data is really, really important, because I think that there's, from what I understand, like all the journals that I've read, and the tracking of all of this looks really, really very, very meaty. I don't know. I'm trying to find the right word for it, but it has a lot of really good information that can be used in future research. So I think as far as qualifying conditions go for a patient, that would be very, very important, because the more we look at this data and to see how people are responding to the medication, I think the outcomes of what is going to be taken from all of this information is going to be really important, not only for the researchers, but also for the patient too, because the more they know about how they are responding to the medication is going to be really important for their healing and getting better. So I think this is just culminating and getting to things that I think a lot of places only, like, maybe some colleges may be doing that for some research purposes, but I think this is going to be even bigger than we even expect it to be. So,
Thank you.
Dan, I think you and
appreciate
your group have been doing a lot of really wonderful work here that I haven't seen before.
And just so this is Ian's work group on the dosage administration and clinical practice committee. So I'm just reporting out from that, since Ian's not here. To get to some of the questions in the chat, I'll go to Ann Metz's, and then I'll move up. Ann Metz had asked, so psychedelic therapists cannot provide psychedelic therapy prep, admin, integration. That term choice seems strange for what seems like a triage and screening role, meaning I don't know the specific answer to the terminology used. However, I will say the note is a single qualified individual should be allowed to fulfill multiple roles where scope, training, and credentialing allow. Then going up the chain to missed it there, Eileen Schemmels. What is the nuances between the facilitator and space attendant mentioned earlier? And so Dr. Lehman mentioned the space role, and I will quickly say that it fits into the facilitator role and definition there, but Dr. Lehman might want to share a little bit more specific.
Sure. We're thinking the space attendant could have less training, honestly, that a space attendant could be someone with a 40-hour training, and that would just focus on the emergency training in his endo and the training for end-of-life care. So we're viewing that as potentially significantly shorter training than for a facilitator.
Thank you. And to hit some of the other comments that happened after that, Eileen Schimmel said, again, I appreciate the detail in the document, but also worry about the terms clinician and practitioner. Those terms are often used interchangeably, and it might help to have more to distinguish them. James Brown, can you expand on the reciprocity piece and your thoughts on who will be able to apply for a permit? And Joan Manuel Araujo will naturopathic doctors, indeed, who are similarly licensed as primary care providers under New Mexico law and are ultimately trained in whole person and plant-based medicine, also be explicitly included in that definition. So to hit some of those questions, to Joan's question, I believe that the best outlet for that question would be to attend the dosage administration and clinical practice committee, since this is a document that came from that, to make sure that that would be something that the committee does here. To James Brown, can you expand on the reciprocity piece? And so that would really be a Brenda question when it comes to education and training. And Eileen, same thing on the clinician versus practitioner. Those terms are used interchangeably. And so again, going back to the dosage administration and clinical practice committee would be where that might be brought up, so that that way Ian and the worst of the work group could ensure that there is a specific definition of those kind of things, clinician and practitioner, so that we can make sure that the vocabulary, the definitions are clear, even though other programs and colloquially we might use those terms interchangeably. We want to make sure that in the medical psilocybin program that those are clearly defined and used consistently throughout. So I hope that helps answer those questions. I know it's not an answer to the question, unfortunately. It's just I can't answer them here myself, and we don't have the committee chair here to answer those. And Brenda, go ahead.
Just to answer James's question about reciprocity and what that will look like. So we're looking at about 10 to 20 hours of the state regulatory compliance and cultural humility in New Mexico communities, legacy and lineage and reciprocity integration, ethical and scope of practice of alignment and safety and risk alignment. And, those who will be eligible, we're hoping that anyone that's had any previous training from a CIIS and Naropa, MAPS, Intertrek, and a host of other places that people have gotten training. Hopefully the DOH will accept a lot of their the training and the certification from those places, especially Oregon and Colorado also, and include that in the reciprocity for those that have been trained. And this would be just an add-on, like 10 to 20 hours for here in New Mexico. So we're can get practitioners and clinicians and other people who qualify with a license and to be streamlined into this. And we will go through that training first. This is what I'm imagining as the DOH finds fit for the core competencies. And then, we haven't really discussed an exam or anything like that, because that would have to be some type of program that would have to be constructed. And then getting licensed, we haven't gone there yet. We're still kind of waiting for all of that. So any licensed, I'm just going to say practitioner for right now, or anyone that's licensed can do the reciprocity, that can show some kind of certification. Or if you are a legacy healer, maybe a letter from your community showing that you have these core competencies, whatever we decide what that will be. And there's a lot of different things here, but making sure that safety is paramount to everything that we are doing here as far as reciprocity goes. And another question that comes up, like, okay, so let's say we have all that in place. Where is this going to be taught? How much money is going to be allotted for teachers? What are the materials are going to look like? And how is this all going to roll out? So, we still have a lot of work to do in the nuts and bolts with that. But as far as reciprocity goes, I'm looking at 10 to 20 hours, and that also includes the practitioner, getting some hands-on experience. But then again, we have this other thing where, okay, where are those patients going to come from if we're trying to do, um, the um, the practice of using psilocybin medicine. So there's there's a little bit of working out there, but I think we can work on that a little bit more and see where that comes to fruition.
Thank you. Thank you, Brenda. Appreciate it. And Desma, go right ahead.
So I think this is like kind of a lot of, I was trying to take notes, so I apologize for kind of jumping around here. I do have a question of clarification for Dominic and the rest of the group, because something was said early on about recommendations and guidelines, and I just kind of wanted to gloss over that really quickly. But then also just more to Brenda's point about getting more input about the tribes and that. My suggestion, and this is open to everybody else, is that when we are kind of coming to these places in our different communities, that if I'm not able to attend, or if, back and forth, like just making sure that, yeah, we can present, that this specific thing in the committee language, has gone over and we've kind of asked in that way. And I know we're kind of sort of waiting for some feedback from tribal liaison and the public council governors as well. And to that point specifically, at least this is just my opinion and my understanding, it would be probably a point to make sure that, like the door, it's more to me like the door is open, that we have the understanding that because tribal sovereignty is important to saying this is, something that we have available to you should you want to adopt what the work that we've done in this particular instance, and then make it work for your tribe and make it working according to what you feel is best for your people. And then of course that takes kind of more of like a diplomacy aspect of it, and again, tribal sovereignty, and maybe some more liaising with that to kind of understand like what would be the best way to approach that. On the other side of that, knowing for sure that we have people such as myself, not living on tribal land, and what does that look like whenever I am going into a facility and working with a facilitator who is here in Santa Fe or in Albuquerque or places that are on non-tribal land, right? So I feel like part of the idea is just making sure that that is an awareness, that the door is open to the practitioner or the facilitator or whoever is working with the person, that they are just understanding, that the person is coming in with this cultural lens, and also to that, on the other opposite side is, people who are city Indians and not raised on reservations, and the assumption that we're coming in with all of this cultural knowledge and teachings and understandings that we're just like, yeah, that's foreign to me. I have no idea what you're talking about. So it's just being open and aware in general that we're human beings coming in with so much. We're also very multi-tribal. So there's a lot of people who have, 5 different tribes that they represent, and they're from all over the United States, and it may not necessarily be just from New Mexico, and they're coming in from Alaska, they're coming in from Canada, they're coming in from Bolivia, they're coming in from different places. So maybe it's just more that, we understand that when we're working in culturally sensitive areas, that we are not essentially assuming anything. But also too, that it's a door open for the tribal sovereignty aspect of it, because we have the 23 federally recognized tribes here in New Mexico. But on that note, the question does become to the questions and to, consolidating the language that we are going to at some point, start making those definitions, that at the end of the year, these are the things that are, as meetings and hearings are adopted and put into place, we are going to have that narrowed language. We are going to have that specificity of the definitions that we're using, because, somebody might use the word journey. I used the word journey someone might say a session or a treatment, and so forth. So we have to be very mindful of that for sure. But I feel like just making sure that we understand that at some point we're going to have those definitions, so that we're using them across the board, and it's going to not be as confusing at the very end of it when things come out of the wash. But on that note, this is where I have the question for everyone else, and just wanted to clarify. As the board, we're making recommendations to the Department of Health. And I heard mentioned that that's not going to be something, it could be in the guidelines. So as we're working through this and we have recommendations that are baseline, then we have like our wish list essentially of all the guidelines and recommendations that we wish could, the people who are really wanting to, rise above just the baseline. And I just kind of maybe wanted a clarification, if possible, from Dominic and or anyone else, if I have that kind of understanding that we have recommendations from the board to the department for their consideration into adopting, and then from there is something else that are guidelines. Are those guidelines then going to also be like, hey, if you want to up your game as a practitioner or propagationist, these are the things that we also, you might want to be able to consider. And I just kind of wanted to clarify that for myself.
Sure. Good morning again, everyone. And Desba, it's a great question. So regulations are really the things that have to be done. So they are items that are going to be required. So for example, with regard to cultivation, it's required that any of the companies that may get permitted have to register with New Mexico Tax and Rev, have a business license, etc. Those are requirements that have to be done. But the guidelines, and really the correct term is actually best practices, are those things, and that's something that we hear all the time, especially in medical clinical fields, where those are things that are really set up as guidelines for providers, clinicians, therapists, that really say, here is some guidance for around this. But each patient, each individual is a little bit different. You are going to have to use your judgment, your experience to actually see how this works with regard to the patient. And what that really does is it gives those individuals a little bit of a pathway on how to determine what's going to work. And they may have to veer a little from that pathway for specific individuals, for things that, for example, we don't know yet. For example, some things coming in are about how things like SSRIs actually may have an influence in how psilocybin uptake occurs in the body. And so providing some best practices about how a clinician or a practitioner could incorporate that into their work to ensure safety for the patient is important. But we don't want to put that into a regulation, because that would then tie the hands of someone. And if more evidence comes out down the road saying something like, no, do not use that medication under any circumstance with psilocybin, then we would have been locked in because of regulations. And so that's why there is that difference. And this is not uncommon in the medical world, as I mentioned, about having those best practices, those areas to help give direction for those practitioners and clinicians, but not necessarily say this is what you must do. And that's actually why the training and education is so important. But that's an example of what the best practices are. And there'll be best practices in that area, best practices for things such as, for the patients within the approved settings, it should be a comfortable environment. What might that consist of? But it doesn't mean if, for example, we say have comfortable seating as a best practice, or places to lounge, that sort of thing, where we suddenly say, oh, you must have a couch, a chair. We want to go away from that and provide, here are some basic thoughts and ideas. And so that's what the difference really is between the best practices and all of that, and the regulations rather. The regulations will be those things that are absolutely required. The best practices, the way I think of it, is it's a pathway for a way forward with for the clinicians, the providers, and the patients. So I hope that helps explain the difference between them.
Yeah, no, I just thank you for reiterating it. And I just kind of wanted to point that out because sometimes I feel, we're like, why aren't we doing this? Or why isn't this this? And then, and it's like, okay, we're looking for baseline. We're looking at things that are just like where we're at, but it doesn't mean that, you can't make this the most best practice and you're going to have a hard time keeping people out of your facility. So I just wanted to make sure that that was said.
Yes, yes.
No,
Thank
it
you.
does, but that's a really good point to bring up because we've talked about that before. It's a lot of times when we talk in our committee meetings, we're talking a lot about best practice and not necessarily the regulation. So it is not something that has been decided. It's just something that is brought up. So it's I'm glad you brought that question up because I think we need to also be reminded of that a lot of times ourselves. So, and it's great to have those best practice discussions because that's how we can really find what, as you said, there'll be the places that everybody wants to be. So at this time, I think on our agenda, we're ready to move into any kind of public comment, but I just wanted to double check to make sure I don't see the agenda. So if you might just double check my agenda for me, please. There we go. So we've already done the update. So and there's, I guess, go ahead.
Dan, before we do that, I do have an item I got reminded about that I forgot during the program update, if that would be okay.
Absolutely. That's the other business part.
Okay. So I just wanted to let everybody know the department and actually all of the various executive agencies have been going through a process on our websites to ensure ADA compliance, ADA American with Disabilities Act, and to ensure compliance on all documents. So I just wanted to let everybody know that as the departments are going through that, there may sometimes be some delays in documents being made available, but we're working on it, especially on documents moving forward, ensuring that they're there and that they're updating older documents as we are best able to do so. But with that in mind, I did want to let all of the committee chairs and board members know we may have some guidelines with regard to PowerPoints or other documents, just to ensure that we're following that and we don't have to convert it later into the ADA compliance, because then that will just take longer for us to be able to then post items. So just to let everybody know, we will be putting that, sending that out to the board members, just so that you're aware and that you can use that, including some templates such as for PowerPoints and things like that. So you don't have a lot that you have to do on your end as well with regard to that. So just wanted to let you all know about that part. And as soon as we have that guidance, we'll send it out to all of you. So thank you.
Perfect. Thank you. Great. And we've got Desba, and then we'll go to Chris.
So Dominic, that means no PowerPoints and papyrus. Our Comic Con.
Yeah, we do need to make sure that the text is legible. Yes.
Okay.
I was thinking wingbats because that's the most understandable font that there is. So.
Okay, so no PowerPoints and papyrus. I just wanted to say that I realize this is really super glossed over the Equity Access Cultural Committee report, and I didn't mean to do that. I was just trying to get through it. So if it sounded like I was trying to get through it, well, that's the reason why. So if anybody has any questions that I could possibly answer about that more specifically, but again, if you didn't understand what I was talking about and you're curious, please come to the meetings. That's your cue. That's your trigger to like, I didn't know what she was talking about. I need to know more. That's why you need to go to the meeting on Tuesday. So that's all.
Thanks, Desba. And then Chris.
I'll be coming to your meeting on Tuesday, Desba, so I'm looking forward to it. I wanted to ask the department if there's any word on or update on when we're gonna bring in our last two board members.
Yeah, thank you, Chris. We actually are going through the process of doing interviews and going through those that have come in, those applications that have come in since our last round had been completed this past fall. But if there are individuals who are on this call right now and who are interested, if you go to the website, and we'll get the link here in a chat in just a moment, but if you go to the website, the requirements for board members is listed there. There's a document on that. And if you're interested, I would recommend applying within probably the next week, give or take a little, because our hope is to get interviews finished, completed and finished within the next couple of weeks, and then to be able to move those potential candidates to the governor's office. So thank you, everybody. And thank you. Great question, Chris.
And then, Donna, one extra question. We're about to go into the next. Oh, go ahead. Back comes Chris.
I was wondering if, so we didn't, I feel like we kind of skipped past going over the document there with the clinical roles on there. And I was wondering, it sounded like in the training and education meeting the other day that the Department of Health had kind of made some decisions to amend that. And I was wondering if we're going to get like an updated version of that to work with moving forward. Or did I misread that? Sorry.
So my understanding, Chris, is that that is actually a recommendation to the Training and Education Committee as far as those clinical roles, and that part of what we presented in the last meeting actually aligns for the most part. There are some differences, but aligns fairly well with it. There also have been, as mentioned, some thoughts and ideas coming from RACI, from the research committee, and from End of Life. And so what training and education, that committee is looking at, and Brenda mentioned this, is to take all of those pieces and sort of put it together into one final version recommendation. But we're not at that point yet. And that's a part of what is going to be happening in the next training and education committee.
Okay. I'm sorry. I think I
Yeah.
misunderstood something.
Not at all, because that was the same thing. I didn't know if this was a recommendation that we needed to take action on as a board, but it wasn't. It was just something to kind of share with the entire group. And then, of course, if there is like, hey, I want to make a recommendation, then Brenda's committee, and of course, as I mentioned, the dosage administration and clinical practice committee also there too. So, and so we're about to set our next board meeting date. And so before we do that, I did want to ask Dominic, is there something that for this board that we need to look at, that we need to bring to the next board meeting in order to make a final recommendation so that we can move something forward? So that way it kind of dictates the rest of the pacing for different groups and when we put that date.
Not specifically yet at this point, Dan. The next set is going to be the training and education piece, as we've kind of talked about before. But that is being developed right now. And so I think that's really going to be dictated by when the Training and Education Committee has gotten their recommendations. And that's going to take a little bit yet. So, and we have enough time. We're, like I had mentioned earlier, we're actually in a good time frame and things are moving along pretty well with that. So I don't think we need to say specifically a recommendation needs to be made at the next meeting. However, if there is one ready by that point, then the board, of course, can act upon it.
Perfect. And so looking at the calendar, I know that, we're now at the middle of May, and looking towards the calendar, we've got if we look at the same time in the middle of June, we have a holiday, we have Juneteenth. So I'm wondering, would June 26th, it's a Friday, again, doing the same kind of time, work? And I don't know if it does for anybody or for the team. So just, I'm throwing a date out to say. Friday, June 26th at 9 to 11.
And just to let you know from the department side that it works fine.
Okay, so thank you from y'all. Dr. Lehman says works for me. Is there anybody that it will not work for on the board? Okay, June 26th, Friday, 9 to 11. will be our next board meeting. And so, Brenda, if you do have any recommendations to bring to the board from your team, then we'll be able, and if it's not, if it's just to the point of just what you have worked on at that point, then we can definitely hear that as well too.
Yeah, it'll be just a in a Word document, and we can go ahead and pepper it, change it, edit, use different language if we need to.
Thank you.
So that it'll be just doing one thing, and we could just keep going back in there and working it with each meeting or other committees who also, I'm going to try to meet as many. Unfortunately, I can't meet Despa's because I haven't. Everybody all my clients want to meet in the afternoon, and it's like, come on, guys. I've been trying to move people over, they won't budge. So Despa, I apologize for that. I really would love to attend your meetings.
Yeah, if you just want to kind of like note it, then that we can talk about it.
Yeah, absolutely. And a lot of times, folks, I can't get into the chat for some reason. I'll log off and come back on, and that's why you won't hear from me. Because everybody's jumping in and talking, and it's like, yeah, I want to make the appointment.
Thank you.
Get in there.
And so we've got our next date set. And while we're about to move into the public comment, I will like to read some of the chat into the public comment from the beginning of the meeting. And then while we're doing that, let everybody kind of give the instructions. If you do want to speak during public comment, you will have 3 minutes to speak. Make sure whenever you introduce yourself, whenever you're giving public comment, talk about who you are. Are you from New Mexico? Are you from somewhere else? Do you have any affiliations? Whenever you're ready to do that, you can just raise your hand. We'll call on you in order, and we'll start the timer. We'll unmute you during that time. So just to kind of go back, while that's happening, I'll read into the chat. Dr. Linda Fatemi said, I would like to inform everyone of a very educational film with heavy presence of veteran stories, trauma healing, and also what's going well and not well in Oregon. Documentary took 2 years to produce, and the screening will be at Santa Fe on Saturday the 16th at John Cocteau Cinema, and Albuquerque this Saturday 17th at 12:30 at the Guild. It's also on Apple TV, Amazon Prime, and then Bruana Wonder, thank you for sharing. Another great film to check out is A Table of Our Own. Experience a critically acclaimed documentary, A Table of Our Own, and a link is provided. Then the links to all the meetings were provided after that. And then into the next set, Senator Steinborn, great job, everyone. Thank you very much, Senator, for being here. Gregory Evans Papyrus, no. And then there's the links there for the advisory board application. And now the links inside of the chat are from Dr. Lowe about how to raise your hands. And so now that I have read everything in, there should be lots of hands raised because I've given lots of time. That was the wait time. I'm not seeing any hands. That's why I'm laughing. There we go. I'm starting to see hands being raised. So I'll turn it over to the DOH team then to start to call on everybody. And please appreciate your public comment.
All right, thanks. And Gregory Evans, your mic is enabled. You can unmute.
I wanted to touch on a request that Desba made a while back for kind of a deliverables workback schedule for each of the committees, and see if there has been anybody working on developing something like that so that we can visually see what our like target deliverable window dates might be.
So Greg, I can answer that. That's actually something that's up to each committee to determine what their deliverables are. So, and I do know in different committees, some of the committees have actually discussed that during their committee meetings. So, but there's not any master document because really what the department is looking at is as far as from the regulation standpoint and working on that. And we've kind of outlined that, and that time frame changes a little bit depending on how much information we're getting, how much information the committees are getting, and based upon those recommendations. But the overall idea is to have the regulations with regard to the next set, which is the training, the education for providers, clinicians, et cetera, is really to have that by the end of this summer. And then with regard to locations in the fall. And that would be the approved location. So places applying to be facilities, wellness centers, whatever terminology people would like to utilize for that.
Places people do things.
Exactly.
Yeah. Yeah, I mean, I think on top of that, I think from a contributor standpoint, like slowly and gradually getting to the point where we understand what the definition of done is, and versions of done. Because like we're gonna deliver a thing and then it's gonna shift and move and we're gonna deliver a new thing. But yeah, I think I'm a visual person, would just love to hear more cross committee understanding of the way the ship is moving, so we're not just floating in the water alone. And that's all I have. Thanks.
Thank you.
Right. Let's see. Next we've got Paul Walton. And Paul, I've enabled your mic and you can unmute when you're ready.
Hi, everyone. Paul Walton here, and firefighters for plant medicine. Thank you all for all the work that you guys are doing. This is starting to shape up and looking really good. A couple questions. The first question would be, I don't know if this has been brought up or not, but I know we have some funding for helping people get treatment and everything, and which is fantastic. And I'm wondering if what the possibility of in the future continuing some kind of other funding, so that there's kind of a rolling, I guess, backbone to that funding for help in the future for people, because I'm sure that that money is going to run out at some point, obviously. But then the other question would be, or other thing that might be brought up, and I don't know if this would be part of the training or if it would be with the Department of Health, but as facilities kind of come online for people to go to and get treatment, one of the things that would be really beneficial and helpful, I think, is doing some education. And it doesn't have to be an incredible amount of hours or anything like that, but just for local EMS, first responders, law enforcement, things like that, that might be responding to a facility that someone's having a challenging or a medical emergency at, just so that they are aware and understanding of what is going on with psilocybin and treatment and things like that, that would help to reduce harm to someone that might be going through some kind of a medical emergency or something like that. Because the way that we interact with somebody definitely obviously has impact on furthering their possible challenging moment, whether it be medical or with the medicine itself. And so I'm wondering if maybe the state might, or the Department of Health might be interested in doing like a small class or something like that, just for first responders to kind of help them educate a little bit on that topic. And then Brenda, I love the a la carte thing, because I really do believe that, doing any kind of course where you're getting certified to facilitate or anything, those are just really the kind of the core foundations. And just like any other kind of licensure, you kind of drift off into specialty areas and work in things that really are passionate with you, or different things like that. So I really love that a la carte kind of idea of doing further education in specific areas and things like that. And yeah, I think that's all I really have, other than I do think it's really important to have some kind of safety course for facilitators. A lot of medical therapists in different areas like that do have CPR requirements and stuff like that. So I think that some of that sort of basic requirements should be kind of included in those policies. Thank you all again for everything you're doing. Appreciate it.
Thank you.
I just wanted to jump in real quick about the a la carte thing. So that's going to take a little finessing, because there's just a lot of things that need to be we need to be educated on. And like, I'm trying to think of all the pockets that could be potentially filled with an a la carte type of thing. So as the education and training move along, I'm hoping I'll have more input on what people are needing in that type of framework as far as the education and training is, because yes, there are many, many people in this field with specialties and expertise, and we want to be able to try to give as much information as possible as far as safety and patients' concerns are. But yeah, and also to address what that would look like. So just having like a core basic type of thing for right now, and then maybe the Department of Health would be flexible enough to add more to the program as we continue on.
Perfect. Thanks for sharing that and clarifying.
And Desba, did you have a comment to that as well?
I did, but I actually see that Senator Steinborn has his hand raised, and I don't know if maybe he might be answering a question that I'm asking as well, or commenting on.
Sounds good. And we'll go to Senator Steinborn. And Jeff, your mic is enabled. You can unmute when ready.
All right. Thank you, guys. And thank you for the opportunity to speak. First of all, great job, everybody. You just bring a big smile to my face hearing all the amazing work you're doing. So first of all, kudos to you guys and thank you. Secondly, I just, Paul raised it about the funding for the equity fund. So I wanted to mention a couple things. Just so everyone, including Paul, this was one-time money gotten through the legislature. And there's no guarantee, when it comes to future appropriations in New Mexico, unlike the federal government, we have a balanced budget. It's, it's always a juggle between, what pressing things are out there in the state and how much extra capacity we have to do things like this, which is amazing that we have this kind of capacity. A lot of states probably don't right now. What that looks like in the future, who knows? So I say that for a couple things. I mean, we need to really stretch the dollars as much as possible and with the equity fund and maybe, there's organizations out there, maybe cost shares and things like that, if there's other entities sponsoring someone's treatment or, just throw that out there. There might be creative things that we're considering as a program to just try to stretch the dollars as much as possible. But again, the door isn't closed on future funds either. That's definitely true. So I think we're going to see how it goes and, it'll be an evolving thing. The third thing I wanted to mention was the federal executive order, President Trump's executive order on psychedelics. If you saw that a few weeks ago, included a little $50 million item for states, $50 million that he authorized of existing funds out there to go to states specifically that have programs. The language on the executive order is pretty simple. It seems to imply states that have programs, but now we have a lot of states creating new research initiatives by the day. I got a text from an advocate today, national, wanting to kind of talk about that. So I think a lot of people are looking at that money. I certainly am. I sent an email to one of our senator staff in Washington, drawing their attention to the executive order. I included the Department of Health and some others on that. So just so you know, that $50 million is money that's definitely on our radar. And if we can try to bring some of that home to help support any facet of our program, research, Department of Health, equity fund, it's just, but right now, I don't know there's even any ground rules by HHS federally for this money. There probably isn't. But at any rate, I think everyone's clamoring for it. So there's going to be a demand to help be equitable in and of themselves for that funds. And I just want to mention one other little thing that I've been thinking about since the very beginning, which is kind of also regarding the last comment about safety information. There's so many cool things out there on like the Zendo project, but others that are just trying to provide harm reduction safety information that I think it would be kind of cool and appropriate to maybe at some point, I know you have your hands full, to create a little safety education thing out there where we can maybe list some of these resource links. Since we are one of the few programs out there, people will be clamoring for that kind of information. And I think we can be a clearinghouse for a lot of cool different projects out there, including, people operating outside the program, which we wouldn't encourage, but nonetheless, there you go. I'll just leave it at that. I'm over my time. Thank you all so much for your good work. Thanks.
Thank
Awesome,
you, Senator
thanks.
Steinborn. Sorry, just jumped the gun. I actually had a question to just clarify if a senator doesn't mind. I know that we were saying that the funds were non-reverting, but then there was also another thing that we're trying to clarify, I think, as far as how far they were extending into the fiscal year, because I know they started in July, or they're starting this July, and then they will be available until they are maxed out or depleted, and that they are non-reverting. But I think that there was a question as to their availability beyond the fiscal year, I think was maybe possibly the question. But on that note, it sounds like what I'm hearing too is that, it's really important as a community, and for anyone else who's in here, is just, making sure that our representatives know how important that this is. When it comes time for this next legislature in January, it's going to be a long one. It's going to be 60 days. That this is really the time to, find out who are actually, working, creating more legislation, bills, and et cetera, asking for these funds to be, replenished and or allocated, making sure that there's also the Healing Advocacy Fund. We're going to be hearing from, I believe, Hanifa and Denali on Tuesday. So it's really important to realize that, if you have an idea, find your common people in alignment with the people who are wanting to advocate for this. And it can be very specific. And much to Senator's, call to action for us, how are we going to, the $50 million, money will be there dangling in front of us till the end of time. But the problem I've seen so far is like the specifics and how to allocate that money. There has to be a framework and a scaffolding of exactly how that's going to be executed. And that's what will get people to listen to you. That's what will get conversations going. And so really being, like, hey, this is exactly how we're going to be able to use money. This is exactly who we're going to be targeting for, these types of things will actually, that's the thing that people want to hear whenever they're being asked to give money or spend money or use money. Okay, and that's also the disappointment when we find out, well, they had, $1 million for this. Like, what happened to it? It's because the planning needs to be there. So even if we don't have the money available, what is the dream that you need to be able to have for this thing, right?
Thanks,
Put the
Desmond.
planning in action.
And I think that the senator might want to respond, though.
Oh, okay. Yeah. And then I just want to put one more thing, and then I'll give the mic back to Senator. It was just the EMS response. That would be great to be able to have recommendations for us or anybody else. But I, as far as I understand, we want people to be there to support others. And sometimes, even if we ask, they may not be willing. I feel like, yeah. So, that's something to be thinking about. We can put recommendations and we can ask people to be there for others. And sometimes it may not, it may fall on deaf ears. So that's it.
And then, Senator, I don't know if you needed to respond back to some of those with the Desmond, and then we can go to Jason.
Yeah, just real briefly, I totally agree, Desba, on the scaffolding, and it's cool the work you're doing, like thinking through all the different ways that someone would need to be supported to use the program, and I think that's great, and it's be really interesting to see what you guys come up with. Yes, the fund is non-reverting, so the money is there until we use it, so you don't have to worry about us losing it. It's not going to go away, and the session is going to be right after the program starts, so can't imagine we'll go through it all in 1 month or 2 months, but any rate, but yeah, there you have it. As far as raising more money from the legislature, though, I want to kind of just flag, I think, something more urgent, but not necessarily less important, but which is that for the Department of Health itself, we got seed funding for the program, which was $1 million. We had initially asked for 2. I think I'm speaking for myself here. not for the department, unless when, until they're ready to kind of have this conversation, and they do this internally before anything goes public. But I think there's a need for more funding for the program itself, just to hire some additional staff. This has been a great rollout, but as a legislator and just in terms of our legislative advocacy, let's all be aware that kind of like, what is the matrix of things we're going to be out raising money for, and the Department of Health will be kind of at the top of the list for the program itself. So, but then certainly more money for equity and research and things like that are always going to be welcome. So just want to flag that for you guys as we think about the next session. Like, we launched this program, but now we have a new administration coming in. So these kinds of programs, when they get started, get built into base budgets of departments. But at what base budget level will it be recommended from this administration to the next? It needs to be at a higher level in which we launched it. And so this is kind of internal advocacy for this administration, but also the next, and just to make sure the program is fully funded on a staffing level. But then these other things as well. All right, that's all I have. Thanks, guys. Thanks.
Thank you. Appreciate that.
All right, and let's see, we are going to go to Jason Burge. And Jason, I've enabled your mic. You can unmute when you're ready.
All right, thank you. Yes, my name is Jason Burge, and I'm with the Psilocybin Assisted Therapy Association. And one of our programs is First Responder Collective. I'm a retired first responder who's used the state programs to address PTSD. I really want to just kind of piggyback on what Paul was saying on the importance of educating all of the first responders that are out there. Because as we've seen in Oregon and in Colorado, which we've been involved in both of those states as well, is that you get an increase of unregulated use of psychedelics in the states when these programs come in, because attention is being drawn to them. So educating the first responders on how to respond is more than just educating on how to respond to a regulated program call. It's also responding to all of any other potential emergencies that are out there. And we're developing training around that. And if there's any way that we can help or participate with that, we would love to. And I really believe that these programs should be delivered by first responders to the first responder departments themselves, because first responders educating each other is very different than somebody else who hasn't actually been in those emergency situations. It really all comes down to that, that safety being the central piece. With that, just to say thank you all for what you're doing, and any way that we can help participate, to make the program a success, we're there.
Appreciate it, Jason. Thank you. And then on that, I wanted to read in from the chat into the record. Robert Truckner, Paul, this is Robert Truckner. I've been thinking about your question of preparation EMS for field response. I think education is a great idea. Dr. Lehman posted a flyer for group psilocybin therapy for veterans and first responders with PTSD. We are now open for people who are interested to apply. This is with whole psilocybin mushrooms in alignment with our state program. Feel free to share the flyer, which has QR link. Dominic Zerlo, thank you. Senator Paul Walton, thank you, Senator. Robert Truckner, I'd love to help with that, back from Paul. And then Chris Piscasio with 2. Gregory Evans, yes, thank you. And Desmond, good note. Senator, it's good to know what specifics needed to be focused on as we move along. Eileen Brewer, we started a list of third-party resources, for example, Zendo, Fireside, for the public as part of the Research and Continuous Improvement Committee. Happy to share with anyone who wants to add it. And I think we're ready for James Brown.
All right, and James, your mic is enabled. You can unmute.
Morning, everyone. And again, thank you so much to the board members and to the DOH for, for having this where we can come and present ourselves and talk to you guys and let you know our comments, but also just for your time. This space is very important, and that these people's containers are very important, that we fulfill what we need to change and what we need to do in this great momentum time that we're in right now. I think New Mexico is in a great place to be forefront and to be leading this industry we need to look at that and think about that with our filters that we use. And one of those, and it's the theme that we're hearing, and something that I wanted to bring up earlier, was some type of quality review board. I believe that the DOH needs a process for a quality review board that will help to reduce this, what we call harm reduction in this space. Colorado and Oregon have a great setup. They have some great tools. They have some great things that we can use. But again, this is New Mexico. We're more rural than they are. We have to think about that. We have to think about our economy. It's a lot different than both of those states. And so with those filters that we're thinking of, we really need to think about that harm reduction process and what can we get from the data that we're going to be collecting. I think that's going to be the key. I've always been a big believer of what do you do with the data that you collect? If you don't do anything with it, don't collect it. So what are we going to do with it, DOH in New Mexico? That's going to be a big important thing that we need to discuss. And with that data, harm reduction is going to be in there. And so as we keep hearing, whether it's a challenging event that we like to use right in the moment, and that person trying to adjust their container could have challenging events. Or is that a more adverse event and something that really needs to be addressed by EMS, that needs to be escalated? And that's in the training, right, that we're going to adjust. But that needs to be adjusted with a thought process of some type of quality review process of the DOH coming up with members of its own, maybe board members, but also independent professionals who are out there in the communities that they would like to see on this quality review board that would be reviewing these challenging events, but also adverse events that come up so that we can use this harm reduction data in a constructive way. Also, that can be used for money. If you guys think about the data that's created, that also leads to funding. And so I just wanted to let you guys know that that's a big piece I'd like to see, but I'd also like to see that with the individual, either facilitators, individual practitioners. Again, definitions is a huge thing here. You know, we need to nail down these definitions like we've been saying. Once these definitions are laid down, I think it'll be very important foundations. But this thing needs to be laid down with individuals. I think harm reduction should start with the individual facilitator, again, the practitioner, the center. All those need to have a harm reduction process and procedure. That's not a guideline. Again, it's not a guideline. This is a process and a procedure. That's a policy. This needs to be laid out to be very, very clear that these policies are there and that we're going to be collecting this type of data in positive ways and in also negative outcomes as well, which I'm hoping are very minimal. But we need to think about that on those levels, that each center will have a harm reduction process. And so when you guys go in to inspect them, you'll have those harm reduction processes, you know, reviewed. And so that's just my idea there is, you know, is I think that would be some teeth into help with harm reduction. Thank you again so much for what the board's doing. I really appreciate you guys, and thank you.
Thank you, James. Appreciate it. And make sure that, I mean, I know you're on the intersessional work group for the RACI committee, because that's exactly where we want y'all to make those recommendations to say, this is the exact framework that we would like to see. And if you want some specifics in there, you're in the right spot for that. So thanks for your participation in that and for the passion for that too. That's exactly who we need. So thank you. Adding into from Eileen Brewer's comment, LEAP Maps and a few others have programs to educate law enforcement. First responders might be worth reaching out to them. And as we approach the end of our time here, if you want to send any kind of written public comment, and make sure you send it to the medical.psilocybin at doh.nm.gov address. And you can include in the comment line for this one, the board as a subject line. If you're referring to any specific documents, then make sure that you do not include the document, but just give us a hyperlink to it. If you do send documents, provide the snippet and the context in there. Comments are related to the topics discussed in the minutes, and other details there, no more than 3 pages, and include your full legal name and organizational affiliations by 5 p.m. of this business day after the meeting. And I see no other hands up, and we are about 6 minutes to the end. So I wanted to thank everybody very much for being here today for the board meeting, and I appreciate y'all's ability to let me lead you through this as co-chair. Thank you again very much. Our next board meeting will be June 26th from 9 to 11. And don't forget, we have plenty of other committees that have their next meetings coming up. So please, DESBA's meeting is coming up May 19th. Training and education is coming up on the 22nd. Qualification and safety on the 26th. Dosage on the 27th, and end of life on the 5th. And then on June 12th, the RACI committee, and that will be on the reporting framework. Appreciate everybody being here, and have a great rest of your weekend, and we'll see you back next month.
Thank you, Dan, for stepping in, and thank you to everybody for being here today. Hope you all have a great weekend, and thank you very much on behalf of the department.